Welcome, everyone, to the Intersection Podcast. The Intersection is a project of the Robert Wood Johnson Foundation. It's a space for advocacy and healthcare leaders to talk to each other and share how they're trying to build anti-racist healthcare systems. You can find us online at meetatheintersection.org. Hi, I'm Anton Gunn, and I'm happy to be joined today by three guests who are all a part of the Health Equity Collaborative in Houston, Texas. The collaborative is working together to measure and share their progress towards building an anti-racist healthcare system in their community. Welcome to the podcast, Hope Galvan, Vice President of Harris Health, Melanie McGuire, Senior Director of Programs at the Houston Food Bank, and Dr. Shreela Sharma, Director at the Center for Health Equity at the University of Texas School of Public Health. Melanie, Hope, Shreela, it's great to be with you. The three of you are in the same city doing the same work around how do we measure outcomes, report our wins, what does success look like when it comes to health equity, social determinants. You're trying to make progress and you guys are doing an amazing job. So Hope, I'm going to start with you. I know you've been in this space for a while. So if I'm in an organization or an institution and in a community that's newer to social needs screenings, what's important to demonstrate so leadership is bought in? What would you say would be the metrics that will be most important for me to demonstrate so that my leadership is convinced that this isn't just the right thing to do, but it's also going to deliver an ROI? So we know patient and family stories are always powerful, but what other data sources would be critical?
I think from my perspective, that's a loaded question, right? Because at the end of the day, Anton, you have to be able to tell the story, right? Okay. And as somebody who's trying to advance, accelerate, create health equity, it can be very challenging because a lot of folks think, what's in it for me? What's helped us has been in working with our health department. They put out the community health needs assessments and different things that we can learn from as a safety net. I don't have all of those resources where I can go do this work by myself. Having partners like Shreela, who's already having these conversations and pointing me to data that they have as a public school, right? That I can then create a story to then take to my leaders or take to my community. I'll give you a quick example. I went to a community meeting and I'm all about accelerating heart health because we have a center for accelerating health equity, but our first focus is heart health. Heart health includes hypertension in pregnancy, tobacco, and hyperlipidemia, right? So I'm thinking this is what we want to do to create heart health. When I go to the community doesn't want to hear it. They're talking to me about environmental health. What are you doing about the trash that's here? What are you doing about the toxins? Like, great that you're talking about that, but we need this taken care of today. But because I learned from our different partners in Harris County about what exactly is going out through data in the community, my internal data from what our patients are expressing when they come into the hospital, and then partners that also help me with data like UT School of Public Health, I have a story to tell the community that how does this toxic waste that you currently have impact heart health, and how can we actually do these things together? I think it's a combination of things. It's not one thing. It's a partnership in the data and what you know about your community. And then last but not least is having our leaders go out and hear the stories and hear firsthand helps me when I go tell them, this is why I think we should, focus on heart health, or my chief health officer, whoever it is that's going to have that conversation with them.
Fantastic. It's the stories that matter more than anything else because it gives context to those things. So Melanie, if I'm just getting started in this direction, what are a couple metrics that would be good for me to start measuring to get people bought in more?
Yeah, I would build on what Hope says. I think sometimes we get too prescriptive in our approach to social needs. And I oftentimes equate it to, if you think about a pharmaceutical company who's providing you headache medication, right? Would you hold them to that same standard that, by providing this medication, you're going to likely achieve this result? And so what we understand about social needs is while health conditions are a portion of that, so is their lived environment. So we have to hold this all in context. As we think about food insecurity, what we do understand is that patients are constantly making trade-offs, right? They're choosing whether to access health. And so when we're seeing alarming rates of A1C or hypertension, oftentimes it's because they're having to make difficult choices. They don't have the luxury of preventative care, right? And that has a lot to do with policies around whether they have access to care. And so, we think about it from a community-based perspective. How do we mitigate trade-offs? How do we get them into the doctor's office more frequently so that they can get the treatments and services that they need? And then how do we layer the things that are taking them away from being able to access that care by embedding those services more integral into the patient workflow? And so when I think about the ROI, it's really important to look at what we do understand about patients today who are uninsured. And we understand the cost of an uninsured patient is alarming. We should all be concerned about that, right? From an economic perspective, we should be concerned about that. From the wellness perspective, and from, a sustainability perspective in terms of emergent care. And so the ROI to me is really around how do we mitigate those trade-offs for patients? And it's really embedded into that understanding our patients and understanding the work that we're doing holistically. And then how do we measure it on a consistent basis using the systems and infrastructures that we already have? So, healthcare providers allow community-based organizations to have insight around aggregate information around someone's patient health from a population perspective. And community-based organizations allow healthcare providers to really understand what that neighbor journey looks like for a participant. What does mitigating trade-offs really mean? And then also, we connect them into those social supports through programs.
Yeah, very good. Please go ahead, Dr. Sharma.
No, I just want to add, as Melanie was talking about economics, one of the interesting journeys that I've had to have in this space of coalition building is convincing our leadership in terms of investment in this work, which is sort of a non-traditional from an academic standpoint. Our metrics in academia is grants, and our currency is grants and publications and all the things that come with academic enterprise and also teaching and students. Just collectively, there are 3 organizations together have collaboratively successfully garnered grant funding. We've written publications together. Our students have trained in their spaces, continue to train to this day. As we think about that internal stakeholder building, right, our leadership buy-in, I think you would be remiss to say, let's ignore the current, these metrics are wrong, let's just generate new ones. You can generate new metrics of success, but also while ensuring that some of the existing metrics are also being considered, right? The pathway to change in these spaces, it's like steering the Titanic with these large institutions. You have to know what is the values that's needed to be brought in as well. So that's some of the ways we've navigated internally in an academic institution.
Yeah, very, very good to hear. Let me stay on that. You're an academic institution, and it's a challenge for a lot of people in state-based institutions to continue to do this work around equity without people, having a broader problem with it. Any advice you could share with people as they think about how to navigate difficult spaces to keep the equity work going? What you found have been effective and successful for you, continuing to keep your leaders focused on the right things rather than being distracted by the wrong things?
Great question. And it's something we work on every day in the Center for Health Equity. The word equity is in our center name.
Sure.
And I think one key piece that I have learned in terms of communicating is really focusing on the impact that this work can have, whether it's health impact, whether it's impact from grants, publications, but also the impact on, most importantly, on the community from a health standpoint. So really framing the conversation and the work from that impact standpoint has resonated no matter which groups I've spoken to. The framing has proven to be important.
Dr. Sharma, when you were building the Health Equity Collective, you did 500 interviews over a year. So can you give us some insight as to how'd you build the list of who you wanted to talk to? Were these individuals? Were these organizations a mix of two? And was a 500 a number that you wanted to get to, or did you just happen to keep going?
Great question. We had the initial list of organizations from the Clinton Health Matters Initiative that was in our region for 5 years. So they had a great network, and we were all engaged in that effort around starting to screen for social determinants of health, especially in health systems. As we started talking, it wasn't a list of 500, it was maybe about 80 organizations. And so as we started talking, we realized, you have a conversation, and our main priority in every conversation was, tell us about your experience around social determinants of health, and where do you want this work to go? Where do you see it for your system and organization? And every conversation, it would end by them saying, have you talked to this one? And have you talked to that one? Because if not, you should be talking to them. And so it was sort of the snowball recruitment strategy. So it just kind of grew from there. It's important that I say who the we is. So I was one of 3 we's. It was myself at UT School of Public Health, but there was also American Heart Association and Harris County Public Health, which is our county public health department. These were the 3 organizations that were tapped on the shoulder to initiate this work. We didn't know sort of which direction we wanted to go in. And so to do it meaningfully, we knew we had to talk to all of the important stakeholders. And as we talked to one stakeholder, they led us to the next. We knew that we had reached critical mass of about these 500 plus. We ended up calling it the listening tour, 500 plus conversations. One of the questions that we ended up adding to our list is, who do you think we should talk to? And when it became circular, we knew we had reached critical mass. We went back to our notes and synthesized it. And the synthesis actually helped identify what was the critical need. The critical need in terms of a systems coalition was, how can we come together to coordinate care for our community in social determinants of health? And that's how we came into that space.
Very good. Well, thank you for sharing that. Now, I want to ask you all about you. You all work together. You got a great coalition, a great partnership, totally committed in the community. I heard you mention that sometimes you might text each other at 7 p.m. at night about this work. And the work is rewarding. It sounds like your partnership is rewarding, but we also know it's hard. And so I'm pretty interested in your own personal journey to what makes you want to do this work and what keeps you connected to this work. So Hope, what's the motivation behind you staying committed to elevating the importance of partnership and achieving health equity outcomes and health justice? So share a little bit with us.
I'm very emotional, right? Everybody knows that I cry at a commercial. So for so many years that I've been in healthcare, Anton, I was really tired of admiring the problem. I worked in some of the best organizations, and we have some of the best procedures and best prescriptions and pharma, all of that. And we live in this great nation, right? And in this great state where it's like, why do we have so many people uninsured? And then when they're uninsured, we put them through this whole healthcare system that is fragmented. And then we blame them. Why are you not successful, Mr. Galvan? Why are you back here, Mr. Galvan? Why didn't you take your medication, Mr. Galvan? It's just those things, right, that keep me going, because I'm tired of admiring the problem. I think that I'm, again, very blessed to work in an organization that knows that we can't just throw dollars and bodies at problems, that we're really out to better the health of our patients, having that executive leadership that supports me there, having partners across Houston that care, taking the time, the patience, the tenacity. And so for me, what keeps me here is not only being able to work for an organization that has, again, 44% uninsured, but still dedicating resources to put a food prescription program in place, to put an MLP program in place, because they know that this is important. But being able to be in a big scale, seeing the Center for Medicare and Medicaid say, hey, hospitals, you need to screen for social determinants of health. What keeps me here is to be able to get that data and be able to share it with folks out in the community. How can we work on this together? Because this is what's happening in our hospitals. But these folks are not just in our hospitals and our clinics. These are thriving members of your community. If your community wants to really get better at whatever it is, you have to have help. And so if I can give you and tell you that story, and that's what I strive for, and give a little bit of a clinical piece to the people who are clinicians and who are holding those purse strings, then that's what I want to do. And that's what keeps me here. But you're correct. It's not easy. It's a challenge every day. I'll give you a quick story. When I was thinking about working on the food pharmacies, having those pantries in the clinic, right, to give the optic to patients that this is how important nutrition is, that is right here in your clinic. And this is how we want to help you. It's right here in your clinic. A lot of folks told me, Hope, why are you trying to take care of society's problems? These are clinical people, right?
Wow.
Or I heard, Hope, you're going to bring fruit flies into my space, or whatever the comments were. But that was way back then. That was way back then. If we had given up then, we wouldn't be here today. And so what do you say? We're going to put these things in place so you're not going to be faced with that. And let me tell you how. And in the great nation that we are, no one should be uninsured. And no one should be faulted or blamed because they can't go to their doctor or they can't get their prescription. So that's why I get those 9 p.m. and weekend calls too, because I know Melanie has had outreach from me on weekends.
Melanie, I hear you got a very powerful story about how you grew up and what connects you to this work. I love to learn more about why you do what you do.
Yeah, absolutely. My journey to this work really started in lived experience. I grew up with a single mother who immigrated to the United States, actually to pursue interest in healthcare. And so I really came from it from a systems level approach to understand her journey coming here and kind of navigating the systems. I always am mindful of why individuals constantly have to opt into things, right? Like you have to go here for this service, but you have to go over here for that service. My first foray into food banking, I was on our first program in Louisiana around SNAP. And so there was 2 of us and we covered the entire lower part of the state. And our job was just help people get aware about SNAP. And then if you want to help them sign up. And what we learned was people knew about SNAP. It wasn't about from an awareness perspective. But when we make policies that disproportionately hurt community, it has a ripple effect. And so when SNAP offices were closed down, people lacked the ability to access the service. And so it really helped me understand that the importance of connections and collaborations are so instrumental to our work moving forward. And that's how I always kind of approach this work, and why I'm so honored to work with a renowned health institution. And our research work here is we really have a lot of great built infrastructures in communities. There's a food bank in every zip code of the country. And so I would just challenge individuals, if you haven't connected with your local food bank, to do so and to really embark on this journey together. I think that is where we've really appreciated the opportunity to learn and grow is through those collaborations. And so that's really what energizes me in this work is my own personal lived experience and just knowing what it felt like. I remember going to a senior center and I was the only person helping someone sign up for SNAP. And after the 100th and 10th ticket that they had given out to someone to enroll them, and it was already almost 9:00 at night, I knew there had to be a different way. Thinking about that 13 years ago to where we are today, we've got a lot of work still left to do, but I think it's so energizing, to Shreela's point, to think of all of these organizations that are also on this journey with us, and then collaboratively, how do we work together?
Awesome. Thank you for sharing. And Shreela, I know a lot of academics, but I don't know a lot of academics that's committed to the work like you're committed in ushering this along. So where does this passion and purpose come from for the work that you do? Please share.
Yeah, so it's actually taken me a long time. It's only in the last couple of years that I've been comfortable sharing my story. I grew up a very educated household, but we were in an incredible level of debt, just financial debt, inherited debt. Let's put it that way. As a child, nobody told me. My parents tried to protect me from it, but I could tell from the peeling paint in the walls to we were selling our utensils at home for money, not having enough money to buy milk. Just knew acutely that we were in financial distress. In addition to financial distress, unfortunately, we also had domestic violence at home. all of that to say that I realized as a child how little agency I had on my environment. I was so highly dependent on people around me to support me. And I was fortunate that I had a village. That's ultimately what led me to realize that I want to be in a place where I can work with children and families and creating these sustainable solutions to address these very sticky issues. I'm a trained physical therapist and a dietitian. And so that's how I ended up in the work that I do today. I couldn't be more privileged and honored to be able to do that.
Well, I will tell you that the privilege and honor is all mine to be on with the three of you. You are doing some phenomenal work and have phenomenal personal stories that connect to the work. And I think you've added tremendous value to our audience as you have continued to add tremendous value to the community of Houston and Harris County and all above. Hope, Melanie, Shreela, thank you today for taking part in this conversation and sharing your work. It's been informative, and I appreciate your insights and vision for a transformed healthcare system. I want to thank the audience for joining us at The Intersection and listening to this podcast. For more updates on future events and to join our mailing list, find us online at meetattheintersection.org.